So, just tell me, Jesh, when we can start. Just tell me.
Manohar, you can start, Manohar, so that
Okay, sir.
we save time for introduction and other things
Okay,
before
okay.
the doctors join. And marketing also is going to present. So,
Yeah, I'll not take much time, sir.
yeah,
Just a
yeah,
minute.
please, please start.
Yeah, I think my slides are visible to you all.
Visible,
Yes.
visible,
Yeah.
Manohar.
Yes.
So first of all, good evening to all. On behalf of Merck, I welcome you all, sir. Today we have our welcome to cardiology advisory board meeting with Merck, and which is topics majorly on bisoprolol across CV continuum and what is the evidence, what is the experience, and we seek your insights for today's meeting, sir. And we are continuously doing over the years, and this is one new evidences we have got in the last couple of years. So with this, I welcome you all for this once again for this cardiac crucible. For us today, we have with us our chairing session, Dr. Dayasagar sir, Senior Interventional Coordinator at KIMS Hospital, and he is a direct research and is more than 40 years of experience in the field of cardiology. Welcome you, sir, on board, Dayasagar sir. And with us, we have other, yeah. We have other panelists as well today. Dr. KMK Reddy sir, Senior International College and as Professor at Usmania, and also currently at practicing at Apollo Jubilees, Hyderabad. Welcome you, sir, on board, KMK sir. And Dr. Rajiv Garg sir, today's panelist, Senior International College and Glenlis Aware Hospital, Hyderabad. And we have with us our Muva Srinivas from Senior International College from Pulse Hospital, Hyderabad. And also we have with us BV Purohit International College, Yashoda Hospital, High Tech City, Hyderabad. And we have with us Dr. Sachin sir, electrophysiologist, AAG Hospital, Hyderabad. And Dr. Nirmal Kumar sir from here Banjara Hills Senior International College. Welcome you, sir, on board. And Dr. Baiju Govindan sir, Senior Interventional College, Sri Sri Holistic Hospital. And Dr. Anish Kapadia from the AAG Hospital is a Senior International College at AAG. And with us we have Dr. Sudhir sir, Senior International College, Citizen Hospital, Hyderabad. So with this small introduction, sir, once again, I welcome you all for today's introduction for all the panelists and chairperson, and welcome you all for, and we seek your insights, and it's very much valuable for us to go ahead forward. So with this, I stop my presentation here, sir, and with this over to Jayesh or Vinita. Thank you. Thank you.
Thank you, Manohar. Let me know whether my slides are visible.
Yes, Jayesh.
Yeah, thank you, Vinita. Yeah, good evening, all doctors. We welcome you for this expert meet from behalf of Merck Head Office. So before going to the discussion, few couple of words about Merck. What is Merck all about? So Merck, who we are? Merck is vibrant science and technology company. Science is at our heart, everything what we do. We at Merck, every day, more than 56,000 employees are working across 66 countries to make the positive difference to millions of lives. Merck has a wide therapeutic presence in oncology, immuno-oncology, general medicine, endocrinology, neurology, and fertility. Every day, more than 72 million patients across the world are experiencing Merck medication. Merck is one of the oldest pharmaceutical company across the globe. Globally, it is 355 years old organization. In India, we are 50 years young organization and have the wide portfolio in CM Care, which is cardiometabolic division, which has Concor, Concorium, Euthyrox, and Carbofage. These are the research product of Merck globally available in India. In fertility, we have Gonalef and oncology Erbitux. These are the leading products of Merck globally as well as in India. Today, from the heart, we welcome to the world of Concor. Concor, the innovators of bisoprolol brand, which is available in 117 countries and been experienced by more than 20 million patients every day. We take this opportunity to express our gratitude for your support and guidance, because of which today Concor has become #1 brand of beta blocker in Indian market. In statistics, if I had to put forward, every third prescription in beta blocker is today going for the Concor. Not only that, when you look at the journey of beta blockers in India in last 2 years, bisoprolol has overtaken carvedilol and nebivolol in numbers. This is the 4 years journey where it has been shown that the acceptance has increased in last couple of years. While this acceptance was increasing, there has been a lot of recommendations for us to have the various combinations. And one of it was bisoprolol with ARB. And when we have deep dive into this combination data, it was found that in ARB, telmisartan is the most widely preferred ARB in India. So at Merck, we have taken the initiative and launched the world's number one beta blocker and India's number one ARB, telmisartan and Concor joins hands to launch Concor T in the year 2023. Now, almost a year, this combination is available in Indian market, and there has been a lot of positive feedback on this combination. So, post the launch of Concor T, the portfolio looks like this: Concor, Concor Core small doses, Concor AM with amlodipine, and Concor T. So today we'd like to have your insight, suggestions, and recommendations for us going ahead. Which are the patient profile where we can segregate this portfolio? What are the recommendations on the future combination, what Merck should have with bisoprolol, and how bisoprolol can fairly do well with other beta blockers? With this, I'll take a pause and invite Dr. Dayasagar Rao sir to set the objective for the today's meeting, and then Dr. Harshal shall take it forward with the slide presentation.
Hey, good evening to most of these participants, and good morning to Dr. K.M. Reddy, who is in US and trying to participate from there. I think it's an attempt to rediscover beta blockers in the continuum of care of cardiovascular diseases. I think for a short while, beta blockers were in the great shadow because some data was produced by the hypertensive specialist saying that these beta blockers have not resulted in a decrease in the cardiovascular events and mortality. That was only one study, which was later refuted by all other studies, saying that they still have a role to play in hypertension. I think it is important to remember that although beta blockers have taken a backseat in most of the guidelines in early 1900s and 2000, now there is a resurgence of beta blocker usage in the setting of hypertension as well. If you read the current ESC hypertension guidelines, it can be used. Beta blockers have been proposed as one of the drugs that can be used for control of hypertension. All may not agree with that, but the guideline says that you can use it. Nobody will find a fault for using it as the first line of the drug. I think probably people often forget that the beta blockers are also very useful as an anti-arrhythmic agents. Probably one of the safest anti-arrhythmic agent for control of dangerous arrhythmias, including ventricular tachycardias, are the beta blockers. They do not have any what we call a pro-arrhythmic effects of the other anti-arrhythmic drugs. They are quite safe, and probably most of us as cardiologists use it as a first-line anti-arrhythmic drug in most of the arrhythmias, including atrial fibrillation for control of ventricular rates and ventricular tachycardias as a safe anti-arrhythmic drugs. I think the role of beta blockers in heart failure has been re-emphasized, and probably there is enough data with the bisoprolol to say that it has a track record of effectively improving the outcomes, both morbidity and mortality, in congestive heart failure, courtesy CBIS trials, CBIS trial 1, 2, and 3, thereby showing that beta blockers are no less than ACE/ARB in the therapy of heart failure. And finally, people also forget that at one time we were using beta blockers for control of tachycardia in thyrotoxicosis, not necessarily due to atrial fibrillation, but the tachycardia that occurs as a result of overactivity of the thyroid can be effectively controlled with the usage of beta blockers. I think there are many more interesting indications for the therapy of beta blockers in cardiovascular diseases. I'm sure as we go along with this program, we will find the data on beta blockers is quite convincing, and there's no reason for us to take a back step in the prescription of the beta blockers in the cardiovascular diseases, including as a first-line drug for hypertension. With this, I will open the session and may I request the program to continue with the next speaker.
Yes, sir.
Sure.
Dr.
Sir, thank
Harshal?
you so much
Yeah.
for your opening remarks. And just slides are visible. No?
Yes, Dr. Harshal.
Very much
Okay,
so.
great. Yeah. Yeah. So good evening, all the respected doctors. I think, first of all, thank you so much for joining in for today's Crucible meeting. Especially this is focusing on use of bisoprolol across cardiovascular continuum. And sir has already highlighted main points about the objectives around this meeting. But where we want more insights from all the experts are these areas, because we are at this juncture of bisoprolol journey, Concord journey, where we require further information, further granularity from your rich clinical experience in terms of patient profiles for bisoprolol, and not only bisoprolol, but bisoprolol combinations, which bisoprolol telmisartan, bisoprolol amlodipine, and even which future combinations you see as a potential combination that would be really useful in clinical practice and ultimately beneficial to the patient. So that is first aspect. Second aspect is about usage of bisoprolol in coronary artery disease. And there is a lot of new evidence which is also available for bisoprolol in CAD. There we wish to seek further insights from you around which data points you think are most appropriate and we should utilize maximum in our communications. And at the same time, there are other beta blockers which are also preferred, like metoprolol in coronary artery disease. Is there any factor or any other factors that decides the choice of a beta blocker in coronary artery disease? And last part is about bisoprolol in heart failure and comorbidities. There as well, especially in comorbidities area, the lot of robust data is available for bisoprolol, but we wish to present it to you today to seek further insights on those data points as well. So as we move into first part, there are 4 sections of the presentations, the shorter ones. After each section, there will be some questions for the discussion, but you can stop me, interrupt me at any point of time for any point of discussion. So the first part is basically all beta blockers are not the same. And many of the literature they highlight, though they block the beta 1 receptor, but their pharmacokinetics and dynamics are different. And that's why the unique properties of each beta blocker are different. But bisoprolol carries some unique properties which probably do not have with other beta blockers. And those properties are pharmacokinetic and pharmacodynamic related. If we see the pharmacodynamic property, the first property is about lowest pharmacokinetic variability. And if we see, this is one of the publication which came in 2019, where all the beta blockers used in cardiology, 12 plus, their pharmacokinetic studies were analyzed, studied, and the coefficient of variability was studied for that. And it was found that metoprolol is having the highest pharmacokinetic variability, and bisoprolol found to have the lowest pharmacokinetic variability. And this is among all the beta blockers. And in between, we have nebiolol, carvedilol, and other beta blockers as well. Interestingly, this was not only inter-individual, but intra-individual variability as well. And even long-acting preparation of metoprolol has been studied here. So this is first property of lowest pharmacokinetic variability. And reasons for this have been cited in couple of references is about the CYP2D6 polymorphism, which is seen in 5 to 7% of the population, and metoprolol, nebiolol has that component of metabolism via CYP2D6, which is not the case for bisoprolol, which is majorly CYP3A4. But at the same time, bisoprolol has another unique property of balance clearance, which is 50% via liver and 50% via kidney. Probably all this might have the impact on the variability component. If we see the pharmacodynamic, most of the points are well known, but for the facilitation of discussion, I'm just highlighting again that bisoprolol has 19.6-fold affinity for beta 1 than beta 2, whereas other selective beta blockers such as atenolol, metoprolol has 6 to 5.7 times of affinity, which is way 3 times more for bisoprolol as compared to other selective beta blocker. But what about nebivolol? So there as well, selectivity is very high for bisoprolol, but contradictory evidences exist. Some older evidences before 2000, they talk about nebivolol's selectivity is very high. And this is a recent one from 2001 publication studies done in human left ventricle and the COS7 cell culture. They found that 4 to 5 times more selectivity is there for bisoprolol as compared to nebivolol. So at the end of the day, both are highly cardioselective beta blocker. But one more point which is found and recently in pharmacokinetic is affinity towards beta 1 receptor. And this is identified from this one of the pharmacokinetic studies where dissociation rate from beta 1 receptor is studied. And it was found that as the drug is given, the bisoprolol occupies beta 1, beta 2 receptor, but beta 2, they come out immediately. They're within fraction of seconds or minutes. The beta 2 receptor occupancy becomes nil, 90-degree fall, but beta 1 continues over a period of time, almost 40 to 50 minutes. But the same is repeated for metoprolol or atenolol kind of drugs, or even carvedilol for that matter. There is a sharp fall for both beta 1 and beta 2 receptor occupancy. This shows another way to look at the affinity of bisoprolol towards beta 1 receptor, which is very strong, reiterated again in this article. And then there are many advantages of selectivity, which are also well known. First one is minimal effect on airway resistance, and here high doses of bisoprolol studied, where minimal change in the airway resistance was seen in these asthmatic hypertensive patients, but atenolol high dose increased the airway resistance. In fact, there is minimal effect on lipid and glucose metabolism, so metabolically neutral drug, bisoprolol as such. And the top one are the data points from Professor Cruikshank's textbook, where 36 months of bisoprolol they have been studied and found minimal change on these levels. But at the same time, in India also, BRIGHT study was done. And one more study about 8 weeks of bisoprolol found no effects, no significant effect on the levels of all these lipid levels. And at the same time, along with lipids, the fasting and the postprandial glucose as well as creatinine levels were also didn't change significantly. So minimal effect on even renal parameter as well. And sexual dysfunction has been seen with many of the beta blockers, but these two beta blockers have minimal effect on sexual function. In fact, peripheral resistance is also largely unaffected by bisoprolol. So in one of the review article, it has been highlighted that it can be one of the choice when comorbidity of PVD is there, peripheral vascular disease is there. So in nutshell, with the selectivity, there comes the advantage, and with pharmacokinetic and its unique properties, there are also many advantages, such as less first pass effect or high bioavailability along with that. If we see the bioavailability of metoprolol or carvedilol, it is almost 50 to 60%. But the same for bisoprolol, it is more than 90%. Even the protein binding is 30%, which is giving less likelihood of drug-drug interaction. And naturally, once daily dosing is possible because of its 10 to 12 hours half-life. So with all these points, I just stop here. I just hand over the session to Dr. Dayasagar Rao, sir, for experts' views of their own clinical experiences on each of these property. How do they see in their clinical practice from this
I have
properties?
one question to Harshal.
Yes, sir.
Is there any data how these beta blockers are dialyzable when they are on
Yeah. Yes, sir.
hemodialysis?
Yes, sir.
Because the less protein bound, the more is the dialyzability. And bisoprolol is 30%, but what about the other beta blockers?
Yeah. So, sir, data is available. I have one slide in the heart failure section actually at the end, but the protein binding for nebivolol, for carvedilol, is almost 98%. For metoprolol, it is somewhere 60 to 70%, whereas atenolol, it is extremely low, 3%, and for bisoprolol, it is 30%. But if we see the diazability classification, which is there, so highly dialysable are metoprolol, and the low dialysable are bisoprolol and carvedilol. And carvedilol is the lowest dialysable drug actually by text or by the data.
I think since we are supposed to exchange our clinical experiences, I will tell my journey with the bisoprolol. Actually, one of the reasons why I continue to use bisoprolol for the last 35 years has been that it is a very long-acting drug. So you need to give only once in a day. Probably that can also be said that it's also a disadvantage under some circumstances, especially in the therapy of heart failure when you're starting out very soon after recovery from the ADHF. But by and large, it's a very long-acting drug. And so much so, my observation have been that even if the patient misses one dose on one day, the heart rate does not rise to the same extent as it would otherwise do with metoprolol and atenolol. So they are the three common drugs what we use. Another reason why I choose bisoprolol is its cardioselectivity. It can be fearlessly used in significant obstructive airway disease. And the third reason is now that CKD is rampant in our country. Every third patient in the ICCU has got some degree of CKD, ranging from stage 3 or stage 4 as well. Meaning that drugs which are excreted primarily by the kidney will have a problem of dose adjustment. Whereas bisoprolol has got a dual excretion. If the kidney is not working properly, most of it is cleared by the liver. And the other way around as well, that if the liver is not functioning that well, then the kidney takes over and does the job of what the liver should have done it. Because of its dual excretion, it is very rare to readjust the dosage of the bisoprolol during your long-term management of cardiovascular disease, even in the presence of CKD. So these are all, and finally, from the metabolic point of view now, control of sugars, control of lipids is least affected by the bisoprolol as compared to other beta blockers. At least there is enough scientific data to show that the occurrence of what we call glycemia or hyperglycemia during a long-term treatment with bisoprolol has been found to be least as compared to other beta blockers. But by and large, it's a safe drug, very long-acting drug. Once the patient tolerates it well, you can forget about the dose adjustments, even in the setting of comorbidity. That's my reason. And there's no reason to think twice of prescribing a beta blocker to a young hypertensive patient because it does not cause that the erectile dysfunction, which is not an uncommon thing with other beta blockers. There have been scientific data has shown that erectile dysfunction is least with bisoprolol and nebivolol. So I don't mind prescribing it, and I do continue to prescribe it, the bisoprolol as an antihypertensive drug, especially when you are giving a patient dihydropyridine group of calcium channel blockers. The reason is they cause reflex tachycardia, and reflex tachycardia can be sometimes very bothersome to the patient. They feel that their heart is pounding, and a small dose of bisoprolol certainly adds to the antihypertensive efficacy, at the same time controlling the reflex tachycardia that otherwise would have occurred without bisoprolol. So these are the main reasons why bisoprolol is a very good, effective, safe, and with a good long-term effect. They got round-the-clock 24 hours action. So much so that you don't have to worry about giving the second dose at all. I think these are my observations. If any of my, what do you call, associates have got any other point to make, they may do so. Dr. Nirmal Kumar is there?
Yes, sir.
Yeah, your point of view.
So, I think Dr. KMK Reddy, sir, wish to
KMK.
talk, sir.
Yeah, sure. Go ahead. I'm not
Yes.
able to see who is
Good
there.
evening, sir.
Good evening.
I have a different experience, in the sense, a different sort of experience with the bisoprolol. And I myself got involved in one of the good studies from the Merck almost 10 years ago, where ambulatory BP was the very initial stage. At that time, I think I have recruited almost 40 to 50 patients in that study, and we clearly demonstrated the superior control of heart rate by bisoprolol, and even the so-called the morning surge effects. All those things were taken care. This was compared with a sustained release of metoprolol at that time with a Cipla molecule. And these two things, head-to-head comparison was done. And it was a multi-center study. I think almost 6-7 centers participated in India. And unfortunately, we could not publish it, but it was a very good observation, and the data also was analyzed. And there was a very sustained control on the heart rate and effective control on the blood pressure. 24 hours was well demonstrated. It is a quite a believable and trustworthy molecule in the whatever the indication we prescribe. That is the strong belief and experience I have.
Any other participant would like to make their own observations?
Sir, I think we have Dr. Sachin, Dr. Nirmal Kumar. Sir, anything from your side? Please feel free to comment.
Good evening, sir. Nirmal
Yeah.
here, sir.
Yep.
I think whatever these things points you already these things pointed out, sir. The bisoprolol is a long-acting drug, and we can give on all cardiac continuum. We can give in the coronary artery disease, heart failure, hypertension, and some non-specific indication like a antiarrhythmic also we can use, because in our experience, if we found in the patient has a ventricular VPCs and other thing, I personally found it is a most effective drug. One thing is a long-acting drug, compliance is also good, and we can start with a small dose. So antiarrhythmic, especially when you are using with a Cardron, it is I found it is a better drug. But those the data they are showing the carvedilol and bisoprolol is same. The effectiveness is same with the same antiarrhythmic effect. But bisoprolol, as you have rightly said, it is very good because a highly selective beta-1 blocker. So we can give in the young patient. Suppose that the young patient requires a beta blocker, I think it is the best drug. Though the nebivolol is a drug, but nebivolol we don't have a much data. Like we have with the bisoprolol, we have a very robust data. Young patients are the patient who has a severe COPD patient. We can, and the best thing what I found in the bisoprolol, you can start with a very small dose, 1.25 milligram, and you can titrate with the high doses also.
Okay. Thank you, Nirmal. Dr. Rajiv is there?
No, sir, he has not yet joined.
Not yet
Dr.
joined.
Biju Govind, sir, and Dr. Bharat
Biju.
Purohit.
Yeah. Dr. Purohit is there?
Yes, sir, he has joined.
Yes, sir. Yes, sir.
Yeah.
So
So
he has,
Rajiv,
he has unmuted himself. Yes, sir, please go ahead.
No, I think it's a pretty established drug over a period of time, and pharmacokinetics and all these things have clearly shown the advantages of bisoprolol in our day-to-day practice, and that's probably the reason why we are so comfortable using this drug, because whether the patient is having a renal failure or whether we are worried about the sexual dysfunction part, or titrating the dose or the robust data which we have with regards to bisoprolol. So whether it is a CKD patient or a patient with liver dysfunction, when it comes to choosing beta blocker, we always prefer this. Main reason is because it's a very highly selective drug, and the beta-1 selectivity, as you have already mentioned, is so high the two drugs which have got the highest selectivity are the bisoprolol and the nebivolol. So if we have to choose a drug with regards to the use in hypertension or heart failure, definitely based on the safety profile and the long-acting nature of this drug and less of side effects, definitely bisoprolol scores over many of its counterparts. And that's the reason why most of the cardiologists they prefer this drug over others. So I think that's what I would prefer to say.
Okay, I think we'll move on to the next session.
Yeah.
Because we have got 3 more topics to cover.
Sure. So thank you so much for sharing those valuable comments. I think from all those comments and experience, it is very clear that whatever the theoretical aspects are there are really seen in practice as well at the same time. And the study sir has highlighted was actually ABPM study, which is comparing bisoprolol versus metoprolol. Right. So I just proceed with the next section.
Yeah.
Yeah. And that section is about the change in the guidelines, which recently happened about the beta blockers in hypertension. So ESH 2023
Yeah.
guideline has also now endorsed the beta blockers as a first-line therapy. And not only beta blocker as such, but also considered beta blocker combination with other drugs as at any treatment step. And this guideline is also highlighting grade 1A kind of a status for use of 2 drugs upfront at the start. And also this guideline has been endorsed by European Renal Association, at the same time International Society of Hypertension. So these are a few points which are there. And along with that, now ESC also going to probably present this year the guidelines on hypertension and CCS. Even Indian publications have come after this around about users of beta blockers as first-line therapy and narrated how even before this guideline also the beta blockers have been utilized in India very strongly. And if we see the unique features of Indian hypertensives, we could gather certain from some references. The first part is about having high sympathetic overactivity in Indians. And there are 2 publications around it. One talks about 62% Indian hypertensives have sympathetic overactivity. And one publication, one more, which talks about 75% population Indian hypertensives, they have sympathetic overactivity. And it is not only high heart rate, but as well some symptomatic presentation also, such as restlessness, tremors, naprovated sweating, or fast speech is seen in the OPD as well. And also high renin levels. Almost this one study talks about renin levels of almost going to 50%, 45.9% exactly. So Indian hypertensives, or in general, they have high renin levels. And that's why we need a comprehensive neuroendocrine blockade, a component of a beta blocker and a component of a ARB. And that's why bisoprolol telmisartan recently launched to provide this comprehensive neuroendocrine blockade, where SNS and RAS both are majorly involved in the hypertension. And we could gather how these 2 drugs act together. And there is one in review article which is also highlighting its importance, because guidelines do not talk much about ARB and beta blocker combination in general. That's why we could gather as much as information from the available literature. And it highlights that bisoprolol prevents the reactive renin upregulation, which is seen with telmisartan. It breaks the positive feedback loop between SNS and RAS, which leads to cardiovascular disease progression in a long run. And a dual RAS blockade, one by telmisartan and one by bisoprolol at beta-1 GG cells. So this is how there is a provision of comprehensive neuroendocrine blockade. But what makes it so special is the unique properties of Indian hypertensives: non-dipping at night, high OSA, high heart rate, high renin, early age of onset, and clustering of multiple severe risk factor, early HMOD. And we have from this point, and after interaction with experts, we also could gather certain patient profiles. But today we wish to gain further insights on this patient profile for bisoprolol telmisartan perspective, especially. It may be stage 2 naive hypertension patient with a high heart rate, or a young middle-aged patient having hypertension but also sympathetic activity, or maybe left ventricular hypertrophy at the same time. Compelling indications with hypertension, CKD with hypertension. And lastly, but the major chunk which is seen in India is hypertension with metabolic disturbances, which not only include diabetes, pre-diabetes, the obesity, dyslipidemia, but also metabolic syndrome at the same time. And Professor Cruikshank's one article we could refer, and we got this information about very high level of sympathetic activity is seen in these metabolic disturbances as well. They have high insulin, high leptin, which leads to high SNS. That SNS also stimulate RAS and lead to nephropathy. They also may play a role in arrhythmias, then non-dipping, and also cardiac artery damage, cardiac damage, and the coronary artery damage at the same time. So looking into this here as well, we wish to seek insights which patient profile are more apt for bisoprolol telmisartan. And we also have bisoprolol amlodipine, where amlodipine has further action on peripheral vasculature, providing good amount of blood pressure reduction and having cardioprotective effects also. There is a lot of literature available for that. So there are a couple of questions we in our mind. First is stage 2 hypertension patients are majorly get diagnosed directly when they present in the OPDs. Is that true? And what percentage you think? And having hypertension and comorbidities, what is your views on from your clinical practice? And at the same time, can we differentiate between patient profiles between bisoprolol telmisartan and bisoprolol amlodipine from the perspective of any particular patient profile, maybe a clinical aspect at the same time? So I just stop here. Over to Dr. Dayasagar Rao, sir.
Okay. I think one of the important things British Hypertension Society formulated at one time was they divided the patients of hypertension into young hypertensives and old age hypertension. And for the young hypertensives, they said you start with the A and then add B in case it is not controlled. The understanding being that younger patients have got a high renin hypertension and older people have got not so high renin hypertension, or what we call a normal levels of renin. By and large, there are exceptions to it. I do agree on that. So at one time, there was a time in the chronology of evolution of antihypertensive drug therapy, the British Hypertension Society deleted B, saying that beta blockers have not been shown to improve the morbidity and mortality. So it was only A. And at that particular point of time, at one time, before the major breakthrough of the ACE inhibitors and the ARBs, beta blockers were used mainly to control the high renin hypertension. People forget that because it's one of the stimulation for the release of the renin is sympathetic nervous system. So activation of sympathetic nervous system releases more renin, more angiotensin II, more vasoconstriction, more hypertension. That used to be the sequelae. So if you can prevent sympathetic nervous activity by beta blockers, then your high renin hypertension is going to respond dramatically. That was the concept on which they said young hypertensives start with A. In those days, A was only alpha blockers. Then came ACE inhibitors and ARBs. So there was a transition wherein A was represented by ACE inhibitors and ARBs. And if you're not getting control with it, you had a beta blocker. That was the thing. Subsequently came in late 90s when the study by Massarelli and Dr. Bangalore, Sripal Bangalore, presented the data and then wrote an article in the JACC saying that these beta blockers are not doing any good to the patient's vascular outcomes. Until that time, B was still there. But after that trial, after that paper, B was deleted from the British hypertension guidelines. C and D persisted. A was left like that. And it used to be something like if AC inhibitors, ARBs were not controlling it, then you add C, then you add D. So it was ACD rather than A plus B plus C plus D. So now there is data to show that there is a need for beta blockers. Now to come to the question, whether we can decipher it at the bedside, whether the patient is a high renin hypertension or a normal level renin hypertension, or whether you can identify high sympathetic activity versus normal sympathetic activity. It is a difficult question. There is no comparative data whether clinical signs can be equated with or can be corroborated by high level correlation with increased sympathetic activity. Be that as it may, at the bedside, if you have got a person who has got a tachycardia, then probably, and then is very so-called hyperactive person, then we tend to say that probably he has got a very high sympathetic activity and heart rate is a good guide. So heart rate high, blood pressure high. So beta blocker may not be a bad idea to start off along with. But remember that more than 70% of the hypertensive population require at least 2 or more drugs. So that's the reason why a dual drug combination, single pill, dual drug combination became very popular. Even now, it is a class 1 indication in the sense that if your blood pressure is grade 2, meaning if the systolic blood pressure is more than 160, the diastolic blood pressure is more than 95, you are justified in starting a single pill, dual drug, different source of actions. You cannot combine 2 ACE inhibitors or you cannot combine a ACE plus ARB. So the patient whose grade of hypertension is more than 160 systolic blood pressure, I think the combination of bisoprolol with telmisartan is a very ideal combination. But I think it has to be driven home. People, this combination was not popularized by the Merck at any point of time, as on now. But I think probably that's a good combination, and probably it will control the renin-angiotensin system more effectively, because ARBs, AC inhibitors certainly raise the angiotensin level to some extent, and that can be controlled by additional sympathetic blockade that might have what do you call a more synergistic effect in controlling the renin-angiotensin system as compared to a single antihypertensive drug. But do we have any head-to-head trials? I'm not aware of it. Whether isolated beta blockers versus beta blockers with telmisartan as an antihypertensive drug combination, or beta blocker with calcium channel blockers. There are lots of combinations, but beta blockers with ARBs or ACE inhibitors, there are some like Cardase Meto, wherein they combined ramipril with metoprolol. They also combined with amlodipine with atenolol, amlodipine with bisoprolol. Are also there. So basically, this is a drug that has to be single pill, dual sites of action. Probably is a appropriate drug for grade 2 hypertension. For grade 1, probably I may be reluctant. Any other colleagues of mine have got any comments? Please go ahead.
In advocating the combination of telmisartan with the bisoprolol, I think that DCGI has already ordered 2 companies to conduct a phase 3 clinical trial. I believe they are on the job. I think we'll get a good data very soon. There is definitely, in Indian population, we don't have a concrete data, even though there is a convincing evidence that the combining both these things have a scientific evidence of synergism and also have a better tolerance profile in addition to the effectiveness. I think we'll get that. I mean, even though the combination is readily available, in the market because of the local state policies and all, they are already in the market, and we are also using this bisoprolol with the telmisartan combination. But the concrete data will come up soon. That is the information I have, and definitely it is a very much indicated combination because when the telmisartan, metoprolol, or there are many beta blockers that are there, and there is a wide variety of spectrum of patients we are seeing, as you have mentioned. It's a good combination. I think it has to go up, and very soon, I think the industry noise also will go up, and probably the younger hypertensive patients will definitely get benefit.
I think Dr. Biju Govind sir has unmuted. Biju sir.
Yeah, good evening.
Good evening, sir.
I had a couple of comments. Basically, Jayasekar sir and Professor K.M. Reddy has also very nicely told whatever we had to hear besides what new points you have told. In fact, some interesting points like beta blockers acting on the juxtaglomerular cells, which is also a very good point, which adds to the synergism of ACE inhibitors. Couple of points. The first thing with the first set of slides which you presented, I just want to make 2 points. I couldn't tune in the proper time by then. One is that I feel that the male importance issue is slightly lesser with metoprolol, with bisoprolol compared to metoprolol, which we usually use. And the second thing is patients who have a bronchospastic component, they tend to tolerate this much better. They obviously carvedilol is the least tolerated. So those 2 points. And regarding what we have just told, as far as ESC raising beta blockers is the first line, I think it's for a particular group of patients, isn't it? When they are not pure hypertensives, when there is an essential reason to give a beta blocker, then it becomes important. Otherwise, it is like it's more than it's like convenience based rather than evidence based. Essentially, giving beta blockers is first line. I would still have a problem, but the combination is a different ball game altogether. But using as a beta blocker as a first line has its own issues, which I'm not comfortable with. But yes, the combination. But having said that, most of the hypertensive patients, which are cardiologists, which like all of us in this panel sees, already have a heart disease as such. So CAD is a component. Many of them have arrhythmias. So a beta blocker would only be on board for most of them. So if a beta blocker and antihypertensives is required, a hypertensive with a CAD, so why not? This looks a good combination for me. But let's see how it goes on. Thank you.
Yeah. Thank you, sir, for those comments. Yeah. Dr. Dayasagar Rao, sir, should we?
Yeah.
Yeah.
I think probably you can move to the third session.
Yes, sir. Yes, sir. So first of all, thank you, experts, again for the sharing viewpoints on these aspects also. There are a couple of points in this also, but I probably I can take those later because there are 2 more sections available. So I just move ahead. So third section is usage of bisoprolol in coronary artery disease. And this area is very interesting and for us also at the same time, because when we see global picture from a Clarify registry 2014, and huge number of patients there as well, it was observed that globally, whichever continent or country we take, the bisoprolol has been the number 1 beta blocker or most commonly used beta blocker for stable CAD patients, even in Asia at the same time. But when it comes to Asia, which is not probably a picture in other countries, where metoprolol usage is quite high, definitely. And also one more point we saw from the NICE guideline 2020, they also highlight one statement that bisoprolol is very commonly used in their clinical practice after ACS. If we see the wealth of evidence available for bisoprolol before 2000, there are many studies are available, but those time at that time, atenolol was the main beta blocker. So comparison was done with atenolol basically. Even that, those studies are also available, but we have selected especially last 10-year study for this meeting, and just wish to quickly highlight those studies for further insights from your side. So first study is about stable IHD patients, where these are 28,000 patients, and this study is from Canada, Ontario. These are angiographically confirmed patient, and they don't have heart failure or MI in the last 1 year, and even they have not taken any beta blocker previously. So they are totally naive patient, stable CAD, probably having no HF and MI in last 1 year, and they are started with beta blocker. So there are two groups, beta blocker receiving group and a non-beta blocker group. If we see beta blocker group, interestingly, 66% of those patients, they were having bisoprolol with them, whereas 28% they're having metoprolol and 4% were atenolol. This 66% is a huge number. When we calculate, it is almost 8,000 patients, and such data is a huge data available for bisoprolol, having 8,000 patients in any of the study. Even if it is a observational real world study, still it's a huge number. One more point which was highlighted in this publication is, before this study, there are many studies, including REACH registry, Swedish registry, and other smaller registry, which says that in such patient population of stable CAD and having nothing like HF or MI in the past, probably beta blocker have not yielded any outcomes in CV in terms of cardiovascular outcomes, basically. So usage limited to symptomatic benefit. But this is the first study with a large number of patients and having larger component of bisoprolol. It has shown over 5 years, 8% relative risk reduction in a composite of death, hospitalization for HF as well as MI, one of or all of them. And this 8% reduction is one outcome. There is 13% relative reduction in the hospitalization for MI, future MI. So this 5-year outcome highlights about mortality benefit with beta blockers in such patient population. So this is first study after so many years. And they also cite the reasons why this study is positive and earlier studies might be negative, because the number of patients. Second, maybe the power of the study. And third important reason they cited, the older studies had a patient receiving beta blocker even before they started recruiting in the clinical studies. So probably the beta blocker benefit has already been captured in the previous years. So once they were started observing in another study, probably there is further could not see any benefit. So these are interesting paper came recently. That's why I wanted to highlight here. And consistency is there across the subgroup, whichever subgroup we take, maybe diabetes, maybe multivessel disease, or any subgroup, its presence or absence doesn't show any significant benefit in p-value of p-value. Then there is second real world data. Again, it is from UK clinical database. It is almost 8,000 patients data. 3 groups, bisoprolol group, other beta blockers group, and other than beta blockers group. And follow-up is very interesting. It is followed up for 15 years. The mean duration for bisoprolol was almost 1.5 years to 2 years patient took, and there was then follow-up continuous. The observation is that there are 4 points basically. Hazard ratios reduce significantly for bisoprolol group, almost up to 50% lowering risk of mortality versus other 2 groups. Even discontinuation is less with bisoprolol, 12%, whereas 18-19% for other groups. And this is a significant reduction in angina, embolism, secondary MI, arrhythmias in this study, in this real world study. So it definitely comes with all the advantages, disadvantages of real world study, but these are something which is available for bisoprolol over 15 years as of now. Then third study is BISOCAT study. Heart rate reduction reduces the cardiac composite outcome that is studied here, basically 860 patients, Asian patients. This is done in China, Hong Kong, Vietnam, and India, basically. And Indian data is not captured here for analysis, but Asian population is definitely there. So bisoprolol reduces heart rate from 75 to 67, and also parallelly, there is reduction in the cardiac composite outcome. This is 18-month study. So 1.5 year study has reduced the cardiac composite outcome with the use of bisoprolol. And interestingly, out of this 800 patients, 600 patients, they had hypertension. The improvement in this CV outcomes is independent of the BP lowering effect. So they are trying to say, and they have highlighted, there is an association between heart rate reduction and the CV outcome here. Another Indian study is Tenacity study, which is 1-year study. Post ACS LVSD patient received bisoprolol, and there is improvement in ejection fraction from 41 to 48%. Even heart rate reduced from 85 to 76. And there is neutrality, which also got studied. ST deviation reduced significantly. NYHA classification also improved for the patient. So this is something happened in a real world scenario. And there are 2 more studies, but these are acute setup studies done in UK, basically. These are 600 patients receiving early bisoprolol, low dose, and late bisoprolol, low dose. And they found that the early is better than late, because in early group, all the points, 30-day, 1-year cardiovascular mortality or all-cause mortality found to be significantly better as compared to late group. So this is one in the STEMI set of patients. If we see the same for NSTEMI patients, 400 patients, there as well, ventricular arrhythmias, cardiac deaths, MSE is reduced significantly in the early group as compared to late group. And lastly, always we face the questions and we didn't had much answer except supraventricular arrhythmias. Question was whether bisoprolol has any data in ventricular arrhythmias. And this review article in 2022 got published, and it has all that information. 8 studies on ventricular arrhythmias, and sir was already highlighting about importance of PVCs, which is very commonly seen, and its burden on ventricular arrhythmias. That burden is also lowered with the use of bisoprolol. That is also one point from this study. And well-known effect, robust effect on supraventricular arrhythmias is there, effect on rate control as well as symptom improvement, quality of life. So with that, we just wish to understand further from your clinical experience, how do you see the usage of bisoprolol in ACS setup and CCS setup in our country? And what are patient profile also, which are there any set of patient profile in this segment in ACS, CCS, which specifically needs bisoprolol in that sense? So over to you, sir.
Okay, I think why the beta blockers have got a favorable effect in coronary artery disease. That is the fundamental point. It is important to realize that the major determinants of myocardial oxygen consumption. The angina is an imbalance between supply and demand. So the one major determinants of myocardial oxygen consumption, first one is heart rate, second one is blood pressure, third one is contractility, fourth one is the wall stress. Wall stress, which is directly influenced by the internal diameter of the ventricle, inversely related to the thickness of the ventricle. That probably is difficult to measure at the bedside, but you can measure it by the echocardiogram. But from the clinical point of view, I see a lot of patients' prescriptions by the general practitioners, by the physicians, by my cardiology colleagues. More often than not, there is a cursory dose of the beta blockers. They're giving beta blockers, they believe that they do good. But how does it affect the outcomes? Probably very few really measure the heart rate at the bedside. You not only prescribe beta blockers, But you also make sure that you reach an optimal dose of the beta blockers so that your resting heart rate is around 60 plus or minus 5. That many people are willing to do coronary angiogram faster than what is desired, rather than optimizing the drug therapy for an anginal patient. So from the therapeutic point of view, because of the long duration of action of bisoprolol, is a bit more effective in controlling angina and the adverse coronary events because of the long duration and more effectiveness in terms of reduction of the heart rate. So that is the reason why this drug is favored as an anti-anginal drug. The second reason why you favor it in patients with anti-arrhythmic drugs, instead of using other anti-arrhythmic drugs like Cardarone and other anti-arrhythmic drugs like Encanate and Flecainide. The reason is that most of these so-called specialized anti-arrhythmic drugs have got an adverse pro-arrhythmic effect, which is not there with beta blockers, more so with bisoprolol. It does not have any intrinsic sympathomimetic activity. It has only but it's there's no comparative data between bisoprolol and other antiarrhythmic drugs like Cardarone. Cardarone, for example, the first drug of choice for people having symptomatic ventricular tachycardia is Cardarone most of the time with structural heart disease. So if they are not getting control, probably we would like to add beta blockers. Or the other way around is the patient has got a coronary artery disease, multiple ventricular ectopic beats. Probably there's a case for adding a beta blocker first, and then see the effect both on symptoms as well as arrhythmias, and then appropriately add further drugs if required. So for me, coronary artery disease with angina is well established, beta blockers. Beta blockers after MI for secondary prevention is very well established. But now there's a question mark whether at the end of 2 years of beta blocker therapy, after an ACS or revascularization, is there a role of beta blockers being continued? That's one of the questions to be answered, because that question has been raised, whether continuing the beta blockers, do they do any good beyond 2 years after an acute coronary event? That probably we have to wait for some more time to get the actual value. Still such time, I think we start beta blockers and continue it forever, as on today. So the third reason why bisoprolol is a drug of choice for people with coronary artery disease and heart failure is bisoprolol. It does not lower the systolic blood pressure as much as the so-called carbidiolols, because carbidiol is a vasodilator and it does decrease the systolic blood pressure significantly. So much so that it is said that if your blood pressure is around 90 millimeters systolic, probably you are better off adding a bisoprolol rather than a carbidiol, because carbidiol certainly is going to bring down the systolic blood pressure significantly. It is undesirable at that level of blood pressure. It may be desirable when the blood pressure is around 140s, because it does decrease the blood pressure to a more desirable level of 120 or 130 by 80. So my point here is, if you're not prescribing a beta blocker in coronary artery disease, you need to have a good reason for not doing it. In my opinion, the only time when I don't prescribe it is when you have already a bradycardia or there is a conduction disturbances within the cardiac conduction system by way of first degree heart block or impending complete heart block. Those are the conditions in which I do not prescribe a beta blocker. Otherwise, I need to write down on the case sheet why I'm not prescribing the beta blockers in coronary artery disease. So it's a very established fact, role of beta blockers in coronary artery disease. my colleagues, other
Yeah.
colleagues in cardiology would like to have any say, their point of view about beta blockers in coronary.
Yes. Sir, coronary artery disease, as you mentioned, it is a compelling reason to have a beta blockers in prescription. But only concern is, suppose if there is an associated instability, conduction abnormalities, or a severe LV dysfunction, probably it is a good practice. You also touched upon in the earlier talk to start with a short-acting beta blocker initially for 24 hours to 36 hours, followed by a beta blocker like a beta selective bisoprolol can be used. And there is no dispute that bisoprolol or a beta blocker has to be used in a chronic stable angina patients for a long term as of now. Only exception is in a post-MI patients or a post-MI LV dysfunction patients, probably initial part like 12 hours or 24 hours, start with a short-acting one, then followed by a bisoprolol like beta blocker.
Anybody else would like to?
Sir, Nirmal sir.
Go ahead.
One point I want to add, sir, regarding the
Yeah.
arrhythmia, sir. When we are giving the cardron to the patient, usually we are adding the beta blocker along with the cardron, sir. With the two reasons, especially bisoprolol, because it's a long-acting beta-1 selective drug. It produces more bradycardia, sir. And it has nullified the pro-arrhythmic effect, especially the long QT syndrome also of the cardron. So usually in the patient who has a ventricular arrhythmias or atrial fibrillation where we are giving a cardron, our routine practice is add a small dose of a beta blocker with a cardron, and later on you remove the cardron because long-term cardron has a lot of side effects. So it continue the bisoprolol. And your second point, you're absolutely right. When you have a borderline blood pressure in the post-MI patient, where there is a compelling indication of a beta blocker, I think the bisoprolol is a better choice than the carvedilol if the patient has a borderline blood pressure, because it's the same 1.25 milligram, it doesn't reduces the blood pressure, patient not going to, and the same time it has a giving a good heart rate control because of the highly selectivity. So the bisoprolol produces more bradycardia. Suppose that the acute MI patient have a low heart rate, then I think and blood pressure is okay. There the carvedilol is the better choice because it doesn't produce so much of a bradycardia. So that's why in this way we select the carvedilol versus bisoprolol. Because LV dysfunction, yes, carvedilol has a more trial, but the new meta-analysis has shown bisoprolol and carvedilol is almost same, and some meta-analysis they have shown a better effect than the carvedilol. These are the 2 or 3 points I was.
Sir, in sick sinus syndrome, after correcting the giving a pacemaker, we can again use beta blocker, I think.
Yeah, sure, because there is a backup by way of
So
pacemaker.
in those subsets also, after putting a pacemaker, we can definitely go with a low dose of bisoprolol or metoprolol.
Rajiv, in the patient with the pacemaker where the atrial rate is very high and the ventricular rate is low, so when you put the pacemaker, ultimately the rate goes very high, and that is atrial assisted ventricular beats. And those conditions you have to add a bisoprolol to reduce the heart rate. Because after the pacemaker, the patient may develop the angina if the patient has an underlying coronary artery. So in these conditions, we need use a beta blocker to reduce the heart rate, and we have already backup support with the pacemaker.
Yes.
These conditions, we are regularly using the beta blocker.
Yes.
Sir, I think Dr. Sudhir sir is there. Dr. Sudhir, Dr. Srinivas, and Dr. Sachin.
Sudhir Koganti is there?
Yes, sir, he has joined. Dr. Sudhir? I think so, maybe because of technical glitch, you won't be able to come in. So we'll
Good
move
evening,
to the...
sir. I'm Dr. Sachin here.
Yeah, go ahead.
Hello. Yes, sir.
Sir,
the question you raised about continuing the beta blockers after 2 years of a ACS, the only thing that comes to my mind is that arrhythmic effects. We see lot of patients having later VTs on occurring even after 10 years of coronary artery, the myocardial infarction. So there is the animal model which shows that there's a paracrine effect in the adipose tissues which develop around this scar tissue. Even the scar may be lesser one. So they also secrete some amount of these catecholamines. So there is evidence in the animal models, evidence to support that we may have to continue the beta blockers in small subset of these patients. So if they have any LV dysfunction or as a residual scarring, we have a reason to continue beta blockers even after 2 years. If there is no LV dysfunction, there is no scarring. Again, it is left line conditions. If they have a baseline high heart rates or they have a compelling indication like hypertension. So that's the one thing which I wanted to add. Most of it you have covered, sir.
Sure. Okay, any other comments?
I think Dr. Srinivas is also there, sir. So if he adds, otherwise we'll move to the next session. Dr. Srinivas?
Srinivas is there?
Yes, sir. He has joined.
Okay.
So maybe, yeah, we'll move to the next session, sir. Then, so any other panelist, if you want to add something, so yeah.
In Indian studies also, it was found that heart rates of Indians are on the higher side. So probably bisoprolol will be in a additive because the average Indian heart rates were about 10 beats higher than the Western in many Indian studies. So probably in Indian scenario, this also can be a...
That was discussed actually.
I joined late, sir. Sorry.
Yeah. That was discussed.
Yeah.
But that the main reason for our Indian people having higher heart rate is their physical inactivity.
Yes. And anxiety also probably is on the higher side.
Okay, please go ahead for the...
Sure.
Yes, sir, we'll move to the next session.
Yeah. Thank you, sir. I just moved to next session, that is heart failure. And here as well, some well-known data points are there, such as CBIS-2 study, CBIS-3 studies, but there is a lot of data, robust data available for bisoprolol in comorbidities. And even the part, sir, you were discussing about dialysability, that will also get covered here. So these pillars are well known to everybody, that SGLT2, MRA, and ARNIs are there along with beta blockers. One point is highlighted from a couple of latest references is high sudden death, which is seen in heart failure patients, and it is almost up to 50%. And even the overall mortality at the end of 1 year, 5 years is still high. Then if we see the CBIS-2 data in a summary format, the all-cause mortality is reduced by 34%. One interesting point among other secondary and exploratory points is sudden death. The sudden death reduction here in CBIS-2 study is 44%, which is way higher than any other drug which is there. In fact, other beta blockers also may not have very high sudden death reduction, which is seen with CBIS-2 study especially. If we see another analysis of CBIS-2, that is dose-dependent analysis from low dose, moderate dose, and high dose across the dose range, the p-value was found to be significant. The survival benefit is noted. That's why when the earlier scenario was there, when beta blockers were not used that commonly. So from that perspective, even this publication has highlighted better low dose than no dose, because at low dose even will work for the patients significantly. And as the patient may tolerate, definitely a target dose can be achieved. But this is the one which is another thing we checked from other beta blockers perspective is whether such data is available for metoprolol or carvedilol. We could not get dose-dependent analysis of other trials as well. CBIS-3 study also has one interesting finding, that is sudden death reduction. It is 18-month study, and at the end of 12 months, 46% reduction in the sudden death was observed in bisoprolol initiated first kind of a group. Then there is one more publication of a switch study where carvedilol, because of its non-selective vasodilatory action, may lead to dizziness and hypotension in some of the patient. And if such patients are switched to bisoprolol, and for 6 months after switch, there is amelioration of dizziness, hypotension, and in fact, NYHA classification is also improved. Class 1, which was totally absent, now appeared. Class 2 improved a lot, big chunk captured, and 3 and 4 reduced. So overall, over 6 months after this switch, there is a lot of improvement which was observed with bisoprolol. And these are those comorbidities: diabetes, AF, COPD, and CKD. The first study is about bisoprolol and carvedilol. Bisoprolol compared with carvedilol in CHF with AF. Survival remains same in both the groups, but cardiac event-free rate is different. It's higher for bisoprolol and lower for carvedilol. In fact, defibrillation rate also significantly higher for bisoprolol. Reduction in BNP heart rate is significantly better for bisoprolol as compared to carvedilol. So this is one study, comparative study, available, bisoprolol versus carvedilol. Second is about diabetic population, and here as the dose increases, there is increase in the the reduction in the mortality. So every 1 milligram increase in the dose of bisoprolol, there is 9% roughly reduction in the mortality. So this one of the advantage which is there. And even non-diabetic, there is p-value remains significant, but when the patient is diabetic, the higher the dose, better the benefit that is also observed. The third comorbidity is COPD, and here a comparative data is available. It is 11,000 roughly patients' data, carvedilol, bisoprolol, metoprolol in a heart failure COPD kind of a patients. And after all the adjustment done for age, sex, and comorbidities, it was observed that bisoprolol is the only one which showed p-value significant for this such kind of a patient population. But carvedilol, metoprolol didn't show any change in all-cause mortality. There is no significant benefit after all the adjustment which are done by this publication. In this publication, there is one more study in the same set of CHF plus COPD where carvedilol is compared now with bisoprolol, and here exacerbation rate was 55% for carvedilol, whereas only 17% for bisoprolol. So difference of 62% was there. P-value remains significant in this study as well. This is the review article which compares all the studies done in this set of patients, CHF plus COPD, where FEV1 was highest with bisoprolol compared to other beta blockers. Even in a head-to-head study, FEV1 was improved only in bisoprolol, but not in carvedilol. Even the exacerbation rates were significantly reduced. The rehospitalization is reduced for bisoprolol significantly. And this one we just saw. So these are all the studies available in a comparative fashion for bisoprolol. And the last part is about diazability of beta blockers. One publication highlights that highly dialysable group of beta blockers, if they are used in a hemodialysis patient with CHF, 40% increase in the mortality was observed. And in highly dialysable group, we have metoprolol, atenolol, and other drugs. In low dialysable group, we have bisoprolol, propranolol, and carvedilol. In fact, carvedilol in the books has been classified as the lowest dialysable drug among all the beta blockers. But one study which published, I could not highlight it here, was comparison of carvedilol versus metoprolol in the same set of population, where principally a lowest dialysable drug is compared with a highest dialysable drug. In fact, in that study, carvedilol shown the 17% increase in mortality despite being lowest dialysable drug. That was one study. And later also there is one head-to-head study between low and the lowest, that is carvedilol versus bisoprolol in same set of patients. Again, here as well, the all-cause death was 34% less in bisoprolol arm as compared to carvedilol, and even MAC's rate is 15% less in bisoprolol as compared, and all are significantly different. The p-values remain different significantly. One reason for this thing which has been highlighted is the intradialytic hypotension, which is seen with carvedilol. So though it is the lowest dialysable, but the issue of non-selectivity and other PKPD profile and causing intradialytic hypotension may be the reason for not having good results in many comparative studies. And the last study is CBIS2 subgroup, renal subgroup, where less than 45 eGFR or even more than 75 eGFR. Across the groups, the survival benefit of CBIS2 remains same. There is no difference. So consistent benefit of bisoprolol across the eGFR spectrum, that is also highlighted. And this is a slide talking about why then bisoprolol is showing so much advantages because of low dialysability, low risk of hyperkalemia, and other PKPD benefits. So these are all the unique features. So I just stop here and over to you, sir.
Okay, I think probably a point is made that sudden cardiac death and total mortality in these beta blockers. I think it is worth remembering that as on today, most of the beta blockers have got that, but maximum benefit in terms of decreasing the deaths in the era of ARNI has been shown with ARNI as compared with any other form of therapy. So much so it is said that don't prescribe ICDs, that is implantable cardiovascular defibrillator, unless you are given a trial of ARNI for at least 3 months, ideally for 6 months, because that has changed the scenario of sudden cardiac death in these heart failure patients. Be that as it may, beta blockers are probably before ARNI was the most important drug in preventing mortality, especially sudden cardiac death. So there is no denial about it. But I think the point has been made about dialysability of the drugs and which beta blocker is going to be more safer for the patient, and which beta blocker is going to have a long-term benefits in terms of reduction of sudden cardiac death. I think bisoprolol, for various reasons, is one of the better drugs. You don't have to change anything. Just prescribe it and then patient is safe and that gets the benefit of beta blockers in the therapy of heart failure. So that's my way of looking at it. So other drugs, I think the point is that it's so difficult to remember so many details about so many drugs being used. So you select one drug which will affect favorably many what you call clinical scenarios. And I'm going to select bisoprolol and forget about the rest, in the sense that start with the low dosage and then build up the dosage, and then don't worry whether it's going for dialysis, don't worry whether his kidney function is deteriorating, or whether any hepatic dysfunctions, or whether he developed any lung infections. So it doesn't matter, you need to continue. But I think one important point to be made here is that if a patient is on beta blockers, please do not stop the beta blockers abruptly for any reason, unless the patient is in a cardiogenic shock secondary to a cardiovascular problem. Otherwise, the event rates are going to be very high. So beta blockers, in case the blood pressure falls steeply and they say that you don't stop the beta blockers, reduce the dosage to the bare minimum. And then when the patient becomes better, hike up the dosage back to the original level. But if you stop it completely, you are going to do more harm to the patient than good. That is one of the trials you need to remember. But by and large, if you are not giving a beta blocker for a coronary artery disease patient or for a heart failure patient, you need to have a good reason for not doing it. And if you are hesitant to do it in the beginning because of borderline blood pressure, I generally insist on my resident writing down, consider adding beta blockers during the outpatient follow-up, so that in case we have, nobody should think that we have forgotten it. And it's a reminder to the person who sees the patient next time that in the OP, we need to consider beta blockers, and then they can give a try again for usage of beta blockers in the particular situations. Any of my colleagues have got any other ideas or any other methods of practice of usage of beta blockers? Rajiv Garg.
Yes, sir. Sir, in extreme COPD cases only there is a, matlab they say nebivolol is better. So that's why the confusion always stays in extreme COPD cases, though it is very beta 1 selective. Any side effects this bisoprolol has? As a doubt I had.
No, actually there was a comparison. Probably, it was shown wherein the recovery of FEV1 was much better with bisoprolol compared to any other beta blockers. So they are trying to project that bisoprolol has got all the ideal properties to be initiated, maintained, and continued. Whether a patient is going for dialysis or no dialysis, or any incidental comorbidities that might occur. At the most, I think what you can do is to decrease the dosage in case of any hemodynamic compromise, but then maintain it to some level, and then adjust the dosage after he recovers from the acute event. So that's the way it is. People might think that nebivolol is a better beta blocker because of its vasodilating effect.
Nitric oxide donor properties.
Sorry? Nitric oxide
donor.
Yeah, there are a lot of theoretical things have been given.
Yeah.
But nebivolol has been tried mostly only in the seniors most of the time. It has not been tried in the very young and very sick patients. Your experience regarding that?
No, only that is the subset where I am using it in extreme COPD cases who are having bad lungs. Only I have tried NA, but I did not head-to-head compare, and I don't have a basis to tell that it is better than bisoprolol. And your thought on the subject is better. We can reduce the dose of beta blocker, bisoprolol, rather than change over. But this is what was the practice, so that's why I asked the question.
Sure. Anybody else has got any other comments?
Sir, younger patient, I think nebivolol is also a good choice because it, as Rajiv is saying, nitric oxide donor. So we can use it in the young patient also if it requires a beta blocker because it reduces the sexual dysfunction also. So I think
bisoprolol is on par with nebivolol as far as the rectal dysfunction is concerned. I'll tell you, this theoretical advantage has been used by many to describe it. But I will tell you the extreme example of how theory doesn't work in practice. Nebivolol has been tried in patients with coronary artery disease and peripheral arterial disease. And surprisingly, when the patients were given nebivolol, they became more symptomatic by way of intermittent claudication. So you expect that peripheral vasodilatation to improve their the skeletal muscle blood flow. But apparently what was happening was diseased vessels were not dilating it, non-diseased vessels were dilating it. There was a steal phenomena and they become more symptomatic by way of claudication. So theory is one thing, but when they tried it in peripheral arterial disease, it didn't work out anything better than bisoprolol. There was a
about carvedilol, sir, in peripheral carvedilol, sir, peripheral arterial disease because of alpha blocker properties also.
Sure.
So what is your experience in peripheral arterial disease, bisoprolol or carvedilol, sir?
I still give bisoprolol. Bisoprolol is fairly safe because it has got no effect upon peripheral arteries. It is about only selective beta 1, no effect at all on beta 2.
Thank you, sir.
So basically, that's the reason why I said out of all the beta blockers, bisoprolol, you can close your eyes and then prescribe. You don't have to think twice. Even though the kidney function may be bad, the lung function may be bad, he may be diabetic, he may have a peripheral arterial disease. All these things are taken into consideration. In all the scenarios, it does work out better including when the patient is going for maintenance hemodialysis. It is not dialysable. So, to me, bisoprolol is the first drug of choice if they are not tolerated. But then one of the disadvantages of bisoprolol is long duration of action. So that is not the first drug of choice when I'm initiating it. But once I have initiated a beta blocker and then they're tolerating it, then I switch over to bisoprolol.
So that's why the bisoprolol is the most marketed drug in all over the world, except India, because of our inertia, sir. Concor has not gone.
No, actually,
we are most beta blocker metoprolol people rather than a bisoprolol. But thanks to the Indian market now, we are coming in a big way with the bisoprolol, and everybody is using bisoprolol now.
Number one prescribed drug. It's not the bisoprolol. Almost 70% of market share is by bisoprolol.
All over the world, Purohit, you see, the bisoprolol is the number one leader in the beta blocker. The two drugs I have found, which was because of a marketing problem, one is the Coversil Perindropil and one another is the bisoprolol. We are not able to use these drugs in India. Selective doctors are using this bisoprolol now.
That's true, sir.
No, it is a reflection of how marketing plays a more important role than the pharmacokinetics and science behind it. So it is true in every profession. That is not the only profession.
Well said, sir.
Thank you, sir. And we take the responsibility of that, yes, whatever has, because in more than now in India, we are celebrating 30 years with Concor. So, and now of late, you must have seen in the last couple of years, we have the separate division and a different promotion for dedicated only for the Concor as a separate division. And looking into the exemptors, now there are also other companies who have joined the hands. So now in coming years, maybe the bisoprolol noise level will go up. And all of you have used it. So probably coming days, you will see the sea change in the promotion of bisoprolol in Indian market as well. So there are certain other doctors also who have unmuted, like Dr. Biju sir and other doctors. So they want to add something, so we can take this. Yeah.
Please go ahead.
Nothing, just an observation that the dialysable part, which Desai Rao sir was telling, it is an important component which many of us forget. Many of the patients who may not be on dialysis when we see them first, over due course, they tend to have a worsening renal function, goes to maintenance hemodialysis. So these people, the nephrologist colleagues have a chart actually how to adjust the drug dosage for patients who have gone on hemodialysis. We hardly bother about this. As long as the patient is not on atenolol or sotalol, we are okay, even with the patient is on dialysis. But obviously, from what we heard today, we have understood that that's not the case. Like even regular beta blockers, which we use, what we call it regular, like metoprolol, also those might have to be adjusted when they are on maintenance hemodialysis, which is not the case with bisoprolol, and that's an interesting observation which I made today. Thank you.
I think instead of using the word regular beta blockers, probably more appropriate, maybe more popular beta blockers.
Yeah.
Okay, I think it has been a wonderful experience for me to share and learn about some of the newer things about beta blockers. Beta blockers continue to dominate cardiology, and I'm not sure where it is going to end. But as of today, with the epidemic proportion of heart failure, the beta blocker usage has risen, and we need to know more about beta blocker usage, appropriate usage of the beta blockers in under what circumstances, and why it should not be stopped abruptly, why the dose titration should be slow, why it started with very low dosage. They are all important things. And I think we are going to learn more about it. There may be some newer beta blockers might be coming. Actually, there was a time, unfortunately, that drug has disappeared from the market. For better to assess the tolerability of beta blockers, at one time we were using bisoprolol infusion, which is not bisoprolol. I'm sorry, it's called a Brevilol, or it is called the very short acting. drug.
Esmolol, sir.
Esmolol.
Esmolol infusion.
9
Esmolol
minutes.
infusion, and then if the patient is tolerating it, we say, well, the patient is ready for beta blocker therapy. Unfortunately, the Esmolol has disappeared. It's called a Brevilol because the word brevi means very short.
9 minutes half-life.
Yeah. It is something like Cangrelor.
Yeah.
Yeah, whose half-life is only 3 minutes or 4 minutes. So anyway, I think that drug has disappeared. We were using it for termination of the SVTs and for
Sir, Esmolol is available in the market.
It is with the
Intravenous?
anesthetic, sir. It is with the anesthetic. In the OT, they still use it.
It's
In the-
available, sir. It's available.
In operation
Okay.
theater, they use it.
Okay, I think it is still worth trying it.
Yes.
In
Yes,
patients
sir. It's
with-
available.
Anesthetists use it still.
Yeah, that's good.
Yeah.
Okay, I think we have finished on time.
Yes, sir.
Yes.
So
Yes, sir.
before
Yes, sir.
closing it, sir, I think we can have the few comments from the closure comments from the every panelist, and then you can conclude the meeting, sir.
Yeah, I'll request KMK Reddy, followed by Rajiv, followed by Nirmal, followed by Biju Govind. Rajiv?
Completely
Yes, sir.
agree about
Yeah, KMK, go on. KMK, go on.
completely agree about the superiority, effectiveness, and safety and tolerability of the bisoprolol. Dispute about it, and definitely in all scenarios, I think it is the leader. I used to say it's a hero once upon a time. Now it is a present hero. We can go ahead and do it. Thank you.
Undoubtedly, Dr. Dasagar is the best teacher. We learned a lot of points. Apart from the company showing so many evidences, the best evidence what I learned today, as Biju pointed out, was the dialysable component of the metoprolol is highly dialysable, so it increases the mortality. It was a new learning for us, definitely. And a lot of points, and the how to use is always an enigma, but with each CME, we improve our acumen to use it, and probably with the combinations to come, it is becoming a drug of choice apart from angina as an antihypertensive drug also. And regarding erectile dysfunction, I think a lot of sexologists say it is a psychosomatic problem, more of a apprehension rather than a real problem. Only 20% accountability is by beta blockers. 80% if you psychosomatically tell the patient that you will be comfortable, I think it should be okay. That is what I have read, Yanni, but I am not sure. It's a lot of Google search people come, so they always tell us to change the beta blocker to other drugs. But as sir was saying, Dasagar sir also, it is almost zero with bisoprolol, and other beta blockers also, if you schedule the patient properly, probably they can continue with the drug. Thank you so much.
Dr. Bharat, sir, anything from your side?
There is never been any doubt with regards to importance of bisoprolol in vis-a-vis treatment for heart failure or angina. The only question mark for all the beta blockers was whether we should be using as a first line drug in hypertension or not. And with the data suggesting that there was not much benefit for stroke and cardiovascular mortality, they made it second line. Now they are again coming back with making it a first line. I don't know what data prompted them to bring it to first line. Probably it is just the combination which is there, because it's just not pure hypertension. Most of the people have their comorbidities which requires a beta blocker that probably might have pushed them to bring it back to the first line. Otherwise, in a pure hypertension, giving the beta blocker as the first line, even if it is bisoprolol, I will be skeptical right now. But definitely, as we know, hypertension doesn't come alone. It also comes with its own problems, associated problems, which makes beta blocker invariably indirectly coming as the first line drug. So if I have to add a beta blocker, definitely compared to or with the experience which we have with all the beta blockers, I think bisoprolol scores over all of them. It's just that it has not been properly brought to the notice of the treating physician. Now that the company is taking a lead, I hope the drug gets its due. Thank you.
Sure, sir. Thank you very much.
Thank you, sir.
And Dr. Govind is a Biju Govind.
Yeah, yes, very much. So
Yeah.
all of you have told everything, but just to as a first-line antihypertensive, I might still not use beta blocker, whatever guidelines say. Guidelines are only that much, it's only a guideline. But having said that, most of the antihypertensive drugs trials have done using atenolol as the comparative beta blocker. So we know atenolol is not to go for beta blocker. We have not even spoken about that drug once in a beta blocker symposium. That itself shows. So when atenolol has been it's like most of the drugs have been compared with atenolol. So essentially, you have chosen a very ineffective or non-effective drug for endpoint benefits. So in that respect, probably beta blocker trials have not done justice properly to the individual beta blockers, but still using beta blocker as a first-line antihypertensive is a little too far-fetched at this point of time. That's what I feel. Thank you.
No, but in Indian hypertensive who are having a lot of anxiety and heart rate, high heart rates, I think still it's a additional of a beta blocker to telmisartan or amlodipine probably is still worthwhile trying.
Definitely, sir. What I mean is a first-line drug.
High sympathetic activity, individuals like IT professionals who have a lot of anxiety, high heart rates, or such kind of people, I think still addition of beta blocker to telmisartan or amlodipine will help.
Absolutely my point was as first-line antihypertensive. Definitely, yes, combination that is a role.
Absolutely right, Raji. I also found initially I was also totally against about the beta blocker in the hypertensive patient because I had beta telmisartan or ARBs or ACE inhibitor, then hydrochlorothiazide, diuretic, then calcium channel blocker. But now we are with the experience now we are seeing a lot of patients of hypertension. We found that the Indian patient requires a small dose of beta blocker. Now they are coming with the Concord T because Concord is bisoprolol is also a very long-acting drug, and telmisartan is a very long-acting drug. So the combination of these two drugs, if you add 2.5 milligram, not very high dose, but a small
dose, but do good.
If you add, they definitely they feel better now. Theoretically, it's small, but scientifically, there's no proof. But still, we found in a day-to-day practice that the small dose of beta blocker with metoprolol with telmisartan, as the Sagar Rao sir has already indicated, that beta blocker also reduces the renin-angiotensin system as well as the SNS system. It works on both the systems, so there's a synergistic effect with the ARBs. So we found that in the combination, it is also good when you don't want to use the telmisartan with the diuretic.
It's worth remembering that more than 75% of the patient requires 2 or more antihypertensive drugs. So basically, whatever first drug you want to choose, you need to choose a second drug sooner or later. And the sooner the better. And there is nothing wrong in using a beta blocker, especially in a clinical setting. Remember that the practice of medicine is partly science, partly art. So you got the feeling whether the patient is highly nervous, anxious, under a lot of stress. I'm not sure whether any study has been done whether beta blockers nullify the white coat effect of hypertension.
Yeah.
Is there any data to that? Because it's worth doing it. It's worth doing it. Because quite often I find that patients say, sir, my recording of the blood pressure in the home is never crossed 120. As soon as they come to the hospital, it goes up to 150, 160. How come? I said, you have to come a bit more number of times to make you feel that it's not hospital, it is your home. So basically, he gets nervous what the doctor is going to tell, what the doctor is going to investigate. That kind of an anxiety is there. So I'm not sure whether there's any dedicated study using beta blockers to nullify the white coat hypertension. Maybe worth doing it. The Merck company can take a lead.
Noted,
Yes,
sir. Your suggestion is noted, sir.
Great. Do we have other doctors who are speaking up, or can we conclude them?
Yeah, I think yes.
Yes,
Dr. Sachin and Dr. Nirmal sir, if it is okay, then Dayasagar sir, we can close it here with your permission.
Sure. Yeah, please do close. I think it's gone beyond the time now.
Sure. So good evening. So,
Yeah.
sir, I'm Vinita Gaur. I head the marketing. Thank you for being with us and moderating the session so beautifully. I think the practical aspects that you have shared with us has really given us a lot of insights. We have been making notes, and as Merck, we really value your time and the kind of deliberations which happened. To all the experts who participated and gave us the practical evidences, not just the evidence, but the practical aspects of their practice. So thank you, sir. And I would like to reiterate, the beautiful point that came in, that it's definitely the marketing which plays a role. And in 2006, when the fiasco of etanolol, happened, metoprolol actually took the lead. We being Merck, we had limited footprints in terms of our reach to various geographies was limited at that point in time. But since 2008 and 9, there has been constant effort by teams, sir, and the guidance that we have got over the years have helped us to become the #1 brand in India. Long way to go. And as rightly said, sir, that we were only positioning initially ourselves with the major trials in heart failure, but there's huge scope, be it in CAD space and hypertension, obviously. So which I can just say, sir, from 2020, my colleague Jayesh was also mentioning that bisoprolol started appearing as one of the most dynamic molecules in Indian pharma industry, among the top 10, which could not have happened without the support of clinicians like each one of you, who have been really great ambassadors for us. So thank you for joining us today, and we'll keep coming back to you. We have to go a long way in marketing and ensuring that the entire science of bisoprolol is percolated down to each and every clinician present in India. So thank you for the the direction which is given to us. We will come back to you in future time, and thanks again, sir.
Sure.
Over to you, Manohar.
Yeah, thanks, Vinita. Thanks a lot, sir, Dayasagar sir, and all the panelists, today's panelists, for excellent deliberations and what we are going to do. Well, you've given some good assignments for us also for marketing, and for us how to develop bisoprolol, how to take to next level to bisoprolol. And after it, sir, bisoprolol usage has come up. So you've seen many companies are launching bisoprolol. So only key differentiation with Concur with other brands, which you already know, sir. The key APIs what we are using in bisoprolol Concur, which is imported from Switzerland across the globe, the same quality which we are maintaining, sir, and there is a zero tolerance in non-impurities in Concur, sir. So this is a major difference factor with Concur, and moreover the affordability factor also, sir. Price also not much difference between Concur with other available preparation brands. So only, sir, we request you, sir, all panelists, when you're choosing bisoprolol, our request always goes with Concur, and now we have come up with Concur T with telmisartan, sir. So my kind request, any suitable patients you come across, same APS we are using in Concur T as well, sir. So thanks a lot, sir, for your time, and all the panelists for your giving your evening time Saturday. Thanks a lot, and have a nice Sunday tomorrow, sir. Nice weekend to you all, sir. Thanks a lot, sir.
Thank you.
Good night to everybody. Bye-bye.
Thank you,
Bye.
sir.
Bye.
Have a
Thank
great
sir.
weekend to
Bye.
all.
Sure.
Yeah.
Lovely meeting you, Dr. Rajiv, again. I can hear. Right. Bye-bye. I will take a leave, guys. Yeah.
Yeah.
Bye.
Okay.
Take care.
Bye. Yes.
Yeah, good show, Manohar. Great.